Welcome to The Code Trade, a podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the Mayo Clinic. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EM PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Next up, we have Parker Quinlan, a PGY1 pharmacy resident at Rush University, who will be presenting on intravenous thrombolysis in patients with ischemic stroke and recent ingestion of direct oral anticoagulants.
I have no conflicts of interest to disclose. And then for introduction, I'll give a quick bit of background, things that you're all probably very familiar with on acute ischemic stroke, its treatments, and why there's conversation around the use of IV thrombolysis when a patient has been taking anticoagulation. First off, a very brief background on stroke. Acute ischemic stroke represents 80% of all the strokes that we see in the US, and there are a handful of mechanisms that can cause ischemic stroke. Things like large artery atherosclerosis, cardioembolism is one of our biggest ones, small vessel occlusion, and then strokes of other etiology, things like moya. But the gist for all these is that there's a clot, and that causes a reduction of blood flow, reduced oxygenation, which leads to ischemic cell injury and death, and that leading to loss of structural integrity and cerebral edema, and really poor outcomes for these patients if they're not treated. Thankfully, we have two primary treatment mechanisms to help us deal with that clotting, prevent more cell death, or potentially allow for reperfusion of tissue that may soon become non-viable. First, we have our intravenous thrombolysis agents. We have alteplase that's been around for a long time, and then tenecteplase, our newer agent that finally got FDA approval for acute ischemic stroke back in March of last year. Biggest differences in administration with those: the alteplase is a bolus and then infusion afterwards, versus tenecteplase, just an IV push medication. And then we also have mechanical thrombectomy, where our neurosurgery folks go in and deal with that clot mechanically. And then now I want to address why patients may be taking anticoagulants like DOACs and then present with a stroke. First, we have secondary prevention. If the patient comes with a stroke, it's a known cardiac source, then there's an indication to give them anticoagulation afterwards to prevent a second stroke. If it's another source, and they may be going on antiplatelet therapy. And then for primary prophylaxis, atrial fibrillation is our biggest risk factor for these acute ischemic strokes. And we have our CHADS VAST score to help us guide on if we should be giving anticoagulation to folks. It looks at things like age, diabetes, cardiac conditions, where if it's a score of 2 or greater for male or 3 or more female, we want to be giving anticoagulants to prevent that stroke risk. And with a few exceptions, the direct oral anticoagulants or DOACs are our agent of choice. Why do we care if someone is taking a DOAC when they come in with a stroke, where we want to give IV thrombolysis? The risk of hemorrhagic transformation is our biggest concern. DOACs increase our bleeding risk in general, and we don't want to cause harm by giving alteplase or tenecteplase and then have hemorrhagic transformation from acute ischemic stroke to a hemorrhagic stroke. And our guidelines from the American Heart Association and American Stroke Association have changed their opinion on how we should be viewing DOAC use in these patients. Our 2018 guideline talks about DOACs as a strict contraindication. They say the use of IV alteplase in these patients that are taking DOAC hasn't been firmly established, but may be harmful, and that IV alteplase shouldn't be given to these patients if they've taken these medications in the last 48 hours, unless we have laboratory tests confirming that normal. That, compared to our newer guidelines that just got published in 2026, now looks at DOAC exposure as a relative contraindication. It says that in patients with disabling symptoms and recent DOAC exposure in less than 48 hours that are within the window for IV thrombolysis, the safety of IV thrombolysis is unknown. But there is emerging observational data that suggests that it could be considered after risk-benefit conversation, thinking about things like bleeding risk when their last dose of the DOAC was, if we can reverse it and that sort of thing. So just if it is old recommendation, IV thrombolysis contraindicating these patients that have been taking DOACs in the last 48 hours. New recommendation, it may be considered with recent DOAC exposure. So now in your EDs, you may have neurology residents or ear docs that don't know about this change of recommendation, or if they do know, they may not know why there was this change in recommendation. And one of our primary studies that drove this change in the guideline is what we talk about today. So hopefully by the end of this, everyone can bring a little bit more understanding to these conversations that you may be having every day, and hopefully helping these patients in these situations. Jumping right into our study design, the study question was, for patients who receive IV thrombolysis is recent DOAC ingestion associated with a higher risk of symptomatic intracranial hemorrhage? For our groups, we have those that received IV thrombolysis with confirmed recent DOAC use. I may refer to this as the treatment group. And then we have patients that received IV thrombolysis but were not on anticoagulation. For the design, the investigator group identified contributing centers by searching for centers that had published literature in IV thrombolysis in the setting of recent DOAC use or had prospective stroke registries. It was an international multi-center retrospective cohort that included 64 primary comprehensive stroke centers. It was conducted across Europe, Asia, Australia, and New Zealand, with most sites being tertiary care centers with access to IV thrombolysis and mechanical thrombectomy 24/7. And then one small thing of note, the data for the control or comparator group, those that were not taking anticoagulation, that was in part drawn from the TRISP data set. And just this because it may, there are some patients in that control group that are not in the 64 stroke centers they're focusing on, so it's a little bit expanded data. But the time period that we're looking at is patients between 2008 and 2021. And then another thing to talk about at this point, the authors also split our treatment group, or those that received DOACs recently, into several subgroups based on selection strategy. You'll see this in both our baseline characteristics and then when we talk about the results of the trial. But the site investigators collected information on selection strategies, including did the centers get DOAC levels before giving IV thrombolysis? Did they give DOAC reversal with idursulfimab, or better known as Paxbind, for treatment, or did they give IV thrombolysis without any levels or reversal done? For our inclusion criteria, we're looking at patients that are over 18 years of age. They underwent IV thrombolysis. And our treatment group had confirmed ingestion of a DOAC in the last 48 hours. Our control group, no prior anticoagulation strategy, but they also did include some patients that were on vitamin K antagonist therapy, as long as their levels were subtherapeutic if their INR was less than 1.7. And no strict contraindication or exclusion criteria for these patients. In states, I can just talk about dosing. Alteplase was dosed according to local guidelines, which for the vast majority of sites was 0.9 milligrams per kilogram body weight, but in Japan was 0.6 milligrams per kilogram. And then for those that used tenecteplase, only the 0.25 milligrams per kilogram was used. For our endpoints, the primary endpoint was the rate of symptomatic intracranial hemorrhage within 36 hours of IV thrombolysis, defined as that hemorrhage with radiologic evidence associated with at least a 4-point worsening on the NH scale. That worsening is just compared to immediately before deterioration. So it could be hour 24 post IV thrombolysis that they were doing okay, hour 25 where they have this acute worsening, and you're just comparing those 2 time points. And then for our secondary endpoints, they're looking at any radiologic intracranial hemorrhage within 36 hours of thrombolysis, and then functional independence defined through the modified Rankin scale score of 2 or less at 90 days following thrombolysis. And that modified Rankin scale score goes from 0 to 6, 0 being no deficits, 2, which was their cap of functional independence, being relatively functional independence, but maybe some deficits from where they were before the stroke, and then 6 is death. For our statistical analysis, when looking at our baseline characteristics, the Pearson chi-squared test was used for our categorical variables, and T's test or Wallace test as appropriate for our continuous and ordinal variables. For outcomes, it was a multi-level mixed effects logistic regression analysis. The outcomes presented were both done as controlled and uncontrolled for known predictors of symptomatic intracranial hemorrhage, things like age, arterial hypertension, their baseline stroke score, premorbid functional independence, admission blood pressure, and admission blood sugar. And then sample size. As far as sample size, the authors communicated that because of missing data on this topic, no formal sample size calculation was possible. Hence, a maximum number of centers and patients was aimed for to ensure maximal precision with the outcomes. Now, jumping to our results. First, our baseline characteristics. This trial looked at over 33,000 patients assessed, 832 in our treatment group, or those that got recent DOAC exposure, and then 32,000 in our control group. Looking at the left, some characteristics that may be putting patients at higher risk of symptomatic intracranial hemorrhage that were statistically different between the two groups. For age, while similar, the recent DOAC ingestion group was on average a higher age, and then also had worse stroke scale score when they arrived to the hospital. Then other things, looking at the right, things like antiplatelet therapy was actually higher in our control group, 35% compared to only 11% of those that were receiving DOACs. Our rate of atrial fibrillation, which was much higher in our DOAC group, 90%, compared to only 25% in the control group, which can be kind of expected. We expect most of our DOAC patients to have AFib as the indication for that. We can also take a second to look at what type of DOAC was being used before they came into the hospital. For about 40%, it was dabigatran, 31% rivaroxaban, 20% apixaban, 8% edoxaban, and then there's one patient where they were on a DOAC, but they weren't sure which. And then, like we talked about earlier, there were some patients in our control group that were getting vitamin K antagonists, like warfarin, 2% of those patients, but all of them had an IRNR less than 1.7 to be able to be included. And then also looking at outcomes and why these patients may have been receiving IV thrombolysis. In our DOAC group, 59% had large vessel occlusion compared to an average of 32% in our control group. And you can also notice the point, tenecteplase was very rarely used, only 3.8% in our control group and 6.1% in our DOAC group. Now, taking a second to look at our characteristics of the treatment groups in particular. In here, you can see the different selection strategies for what hospitals were thinking about before they decided a patient would be given IV thrombolysis. We have 225 patients that got DOAC levels before IV thrombolysis was given. We have 252 that got reversal of dabigatran before they got IV thrombolysis, and then 355 where they didn't get levels and didn't get reversal before treatment. So no, you expect with the IV reversal group, 100% of those were on dabigatran because that's the agent that we have reversal for. For time from last ingestion to admission was somewhat similar between the two groups. You can note that a decent percentage, 17% in those that had levels, 20% of those where we didn't have levels or reversal, and then 50% of those that did get reversal did have ingestion within 12 hours. And then about the same amount had ingestion between 12 and 24 hours. And then less patients had ingestion between 24 and 48 hours. But we did still have a decent amount of patients where we don't know the exact time point that they last took their DOAC. It was 40% in our DOAC plus level group, another 40% in our kind of unknown group, and then 35% in that reversal group. But on average, the time from the last ingestion to admission was about 14 hours in a lot of the patients, a little bit less in that idarucizumab group. INR is similar between the groups. And then DOAC plasma levels for those that we did have was a median of 21 in the DOAC plasma level measured group, and then 83 in those that got reversal. That brings us to our results for the rates of symptomatic intracranial hemorrhage within 36 hours. We have our control, that was 4.1%, compared to 2.5% in our patients that had recent ingestion of DOACs. And then separated further by treatment strategy, 3.1% of those that had DOAC plasma levels measured had the symptomatic intracranial hemorrhage, 1.2% of the idarucizumab group, and then 3.1% of those that didn't have a level or idarucizumab. Looking at our odds ratios, as you would expect, the adjusted odds ratio group has a little bit less of a risk compared to the unadjusted odds ratio, but both positive outcomes are statistically significant. 0.62 for the odds ratio unadjusted and 0.57 when it's adjusted. For our specific treatment groups, those outcomes were generally not statistically significant because they didn't have enough patients, but aligned with our overall odds ratios. Jumping into our secondary outcomes, those with any hemorrhagic transformation within the 36 hours post IV thrombolysis, we saw 17.4% of our control group compared to 18% of all our patients with recent ingestion of a DOAC. Similar outcomes when you look at it by selection strategy, 20% with the DOAC plasma level group, 22% in those where we didn't have a level or reversal, but we see a lower amount with those that did get a reversal agent, only 7.8%. Looking at our unadjusted and adjusted odds ratios, both of these crossed 1, now they're significant. So for the secondary outcome, relatively similar rates between our control group and our recent DOAC ingestion group. Then for functional independence at 90 days with a modified Rankin Scale score, we saw 57% of our control group did have functional independence in 90 days compared to only 45% with recent DOAC ingestion. The unadjusted odds ratio was 0.62 for that recent DOAC ingestion group compared to 1.13 when you were adjusting for the covariates. Unfortunately, we don't see more functional independence in that recent DOAC ingestion group potentially because more of these patients had large vessel occlusion compared to the control group, more mechanical thrombectomy that we would expect to hopefully be responsive to treatment, but this could be a reason why we see the difference in functional independence at 90 days. There were a couple other outcomes that they looked at to see if there was an association between symptomatic intracranial hemorrhage and these differences in selected groups. They asked, did geographical region matter? No. For all the regions that they identified, the 95% confidence interval, class 1. They asked, did the presence of a standard operating procedure matter? Yes. They saw an adjusted odds ratio of 0.54, statistically significant outcome for groups that did have a standard operating procedure. For that SOP, there were different procedures across the participating sites. Some relied on DOAC levels, some relied on levels only if the ingestion was within the last 24 hours. Others looked at renal function. Some sites just didn't have any standard operating procedure, just relied on kind of physician judgment. But from this is that among the sites that did have a SOP, outcomes were better as far as they did have less symptomatic intracranial hemorrhage. And then another outcome that I think we all care about, did confirmed higher DOAC plasma levels, proven ingestion within 12 hours, indicate a higher risk of symptomatic intracranial hemorrhage? No, it didn't, but it wasn't a significant outcome. They didn't have enough patients to find that. But the adjusted odds ratio that they did see was 0.57 across one. Now jumping to our strengths and limitations. I think it was a strength of how diverse the patient population was. A lot of patients were getting dabigatran or Roxaban, apixaban across a lot of different areas with different standard operating procedures. And we do see outcomes defined for different selection strategies. It can kind of help us think, should we be getting DOAC levels for these patients? Should we be getting reversal for these patients? But there are a lot of limitations to the study. The biggest thing is probably with it being an observational cohort design, a strong selection bias. These patients that physicians were comfortable giving IV thrombolysis to, or in the construction of their standard operating procedures, were more likely to give this to, were probably patients that had lower risk of bleeding, more favorable physiology for IV thrombolysis. And we can just think about the clinical judgment that's kind of going through our heads. That may be a reason why we saw the outcomes that we do. And also very few patients receive Schenectady, which doesn't necessarily align with practice now. Then for our authors' conclusions, in this international cohort study, they found insufficient evidence of excess harm associated with IV thrombolysis in these selected patients that were presenting with recent DOAC ingestion. And they found that this was true regardless of the selection strategy and may be consistent with net benefit of IV thrombolysis in these patients. So I like to kind of break down into what do we know before, what does this tell us, and how can I apply it for our prior knowledge. Did know that there was potential higher hemorrhagic transformation risk in these patients, and that DOAC use is common for these stroke patients, and up until now has presented a strict contraindication for IV thrombolysis in many patients that we may see with stroke. What does this now tell us? It tells us that the symptomatic intracranial hemorrhage risk may be lower in these patients that we're being very selective about, that did have recent DOAC ingestion. But in general, we can maybe expect the hemorrhagic transformation risk is not significantly different between groups, though it's unclear at this point if there are actual functional independence gains down the line between these groups. And how would I be applying this? I kind of no longer in my mind think about recent DOAC use as a very strict contraindication. We don't necessarily know at this point if different selection criteria leads to different risk of symptomatic intracranial hemorrhage. That being said, I would focus on patient-specific factors and hospital resources when deciding on if I would give a patient IV thrombolysis. Kind of like the quote-unquote perfect patient in my mind, or the person who would make more sense than not would be a patient maybe with a large vessel occlusion in a rural setting where we don't have access to mechanical thrombolysis of neurosurgeons all the time. And also patients that have very few or no risk factors for bleeding, no malignancy, no liver dysfunction. That being said, I think there's a lot of room for knowledge as far as more so proving it safe with a prospective randomized trial. And thankfully, kind of looking towards the future, we do have that going on in process. The same authors of this trial are doing the DO-IT trial, or the DOAC intravenous thrombolysis trial. It's a multi-center prospective, randomized open label, blinded endpoint trial that's currently going on at sites across Europe and Canada right now that are hoping to recruit 906 patients. But that study isn't estimated to be completed until 2029. But I think we will see in that study, hopefully, more stronger evidence to suggest that the use of vagus thrombolysis in these patients may not have the risk of hemorrhagic transformation that we've been worried about. And here are my citations. And then I'll give a quick thank you to Dr. Giles Slocum for review mentorship. Now I'll open it up to questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.